card?
Don't start it till I've got my presentation.
15 minutes.
Okay, good afternoon everybody, very nice to be here. I'm Director of Public Health Strategy amongst other roles at Public Health England, and amongst my responsibilities in that role it includes overseeing all our strategic work on healthcare associated infections and antimicrobial resistance. So I'm going to talk today about the rise of antimicrobial resistance as a global health security issue. What I'm going to try and do is put AMR, I shall call it for short, into historical context, to talk about the recent inexorable rise of AMR as a health security problem, and then talk a bit about at the end about what we might be able to do to tackle what is a very difficult and perhaps intractable problem. I'm grateful for 2 or 3 of my slides. My PhD student, Jasper Littman, I'll come on to the ethical issues around AMR at the end, and a colleague of mine at Public Health England, Mark Wilcox. I'll just start, before the history, that does anyone recognise what this is?
Algae?
Algae, yes. And relationship to bacteria?
Tell us.
So this is cyanobacteria producing the fluorescent pigments, especially under hot conditions, and also neurotoxins, and there's been work around climate change and environment to do with that. And the reason why I put this up is, in relation to bacteria, we can see this, and you can obviously see it. AMR, one of the reasons it's been such a difficult problem is you can't see it. You can't see it. You can see the sequelae of antimicrobial resistance and the health outcomes, but you can't see AMR. Just to put it in brief historical context, the rise of microbes to get us to antimicrobial resistance. It was back in the 17th century, Anton von Leeuwenhoek, who was a Belgian draper, first saw microbes under the microscope. Semmelweis, people will know, in Vienna in the 19th century, reduced maternal mortality through hygiene and separating out autopsy facilities. Florence Nightingale and hygiene in field hospitals. And as we come through to the end of the century, Pasteur and the germ theory of disease emerged, and whipping forward, 1928 was when Fleming discovered penicillin. But just bear in mind that when Fleming got his Nobel Prize shortly after the Second World War, he said in his speech at the time, it will not be very long before we have the first resistance to penicillin. And as I'll come back, he was right. As we follow through, 1967, the General William Stewart, the Surgeon General in the States, very famously announced it's time to close the book on infectious diseases and declare the war against pestilence wrong. But he was war against pestilence over, but he was, as I will show, he was wrong. So penicillin resistance first in 1948, as I mentioned. The first MDR case in 1955, first MRSA case, 1961. WHO declared TB, multi-drug resistant TB, a global health emergency in the beginning of the 90s. And the British Medical Journal in 2011, we had supposedly the first confirmed case of completely drug-resistant TB in Mumbai. So seemingly things have been getting worse. Antimicrobial resistance is becoming an increasing problem. What have people done to tackle the issue of infection control hygiene, which is, infection control is incredibly closely linked to antimicrobial resistance? Well, one issue is improved hygiene. That's been practiced for many years before penicillin. This is flu isolation wards in the First World War, so isolating people, improved hygiene. Those are 2 ways that we classically tackle infections in hospitals, and the development of new antibiotics. That's penicillin, as I said earlier, in the 20th century, and American soldiers who will come home as a result of that. But in the 1980s and 1990s, things have seemingly got worse in terms of infection control, the rise of antimicrobial resistance, and problems in particular in relation to hospitals, but also primary care. This wheel chart is from the Chief Medical Officer's annual report that came out earlier this year. And this shows you, in the blue are the gram-positive bacteria, and this is organisms causing bloodstream infections over the last year or so in England, Wales and Northern Ireland. We've got the gram-positive bacteria in blue, which were a big problem. It's changing, and the red are the so-called gram-negative bacteria, many of whom we're finding now are increasingly resistant and causing morbidity and mortality. And just to give you another very recent graph, or coming up to recent time, of those gram-negative bacteria, people know about E. coli as one example. And if you just look at the trend here, this is proportion of E. coli isolates that are resistant. And this, you can see, if you look at the grey or the green, the rise over the last decade or so. Now, there has been a bit of a plateau in more recent years, but the rise or the trend in proportion of E. coli resistant is increasing. This is from the 2011 point prevalence survey that we completed, the Health Protection Agency completed across the country, across England. And the interesting finding here in relation to antimicrobial resistance is that meropenem, which is one of the so-called drugs, antibiotic drugs of last resort, was the 9th most common used drug in hospitals in England. It's the 9th most common. It's supposed to be the drug of last resort, but it was, you know, and that's considerable use. And that is because of resistance of organisms to other antibiotics. What are some of the consequences of antimicrobial resistance? These are three charts from papers at the turn of this millennium. And what they show you here, for three conditions, pneumonia, critical illness, bloodstream infections, is the mortality when doctors in hospital have had a best guess in the red at what the organism is, but have proven to be wrong, and the bacteria was not susceptible ultimately to the antibiotic that was given, compared with when an antibiotic is chosen where the organism is susceptible. And in all those three conditions, the mortality, which is what we're seeing here, percentage mortality, is about double. So in other words, the more you guess, the worse the susceptibility, the worse the mortality.
Which is why you prescribe meropenem.
Which is why people end up then prescribing meropenem, exactly. A chart of newly marketed antimicrobial agents. We've got antivirals across the whole spectrum here. I mean, just to have a look at antibacterial agents, and you can see the numbers new that have come onto market over the last 20 years or so. It's slightly different for the others, but if we just look at the antibacterial, you can see there is a diminishing number of new antibiotics being developed. And would you develop a new antibiotic? Would a drug pharmaceutical company develop a new antibiotic? They take 10 years or more, cost a fortune to develop. There's a chance often of them failing in the development at a number of hurdles. If they do get onto the market, we're now talking about, well, actually, we think we need to put you on the top shelf and save you for emergencies anyway, the new antibiotics, so they won't get used. And they're often prescribed for a very limited amount of time. And a lot of the new drug development is for chronic diseases, for drugs that are used, where the big money is, the drugs that are used for chronic rheumatological conditions that are used every day, long term, gastric problems, those kinds of things. So there's not a great reason for the pharmaceutical industry to get involved in the development of new antibiotics. What's happening at the moment? We've got a new national AMR strategy, antimicrobial resistance strategy, coming out. Been delayed. It was held back from April, May this year. It's going to come out in August. I understand it's just got approval from Cabinet Office. These are the areas it covers. The World Health Organization has been quite involved. There's a new WHO resolution on antimicrobial resistance in the pipeline at the moment. Our CMO has been, Chief Medical Officer, has been very vociferous about the importance of antimicrobial resistance. And I was with her at the World Health Assembly in May in Geneva, where she held a session with the Swedish Health Minister, specifically on AMR, which was very well attended, and I believe has led to the new draft resolution. But all that aside, and for leading to the discussion points, I'm worried. There's a lot going on antimicrobial resistance, but I am very worried that it's not going on in a radical enough direction. Now, in the health policy and health ethics literature, there's talk about something called super wicked problems. In fact, in the BMJ, Ilona Kikbush had an article about super wicked problems just about 2 or 3 weeks ago. This is from my PhD student, Jasper Littman. Super wicked problems are those kind of policy problems that are intractable to normal attention and solutions. So examples include, say, climate change or coastal degradation. And they're intractable because traditional solutions don't seem to work. And they've been characterized by having the super wicked, compared with the wicked problems, having these 4 characteristics. Time for finding a solution to the policy is running out. Could be the case for AMR. Those seeking to solve the problem are part of the cause. We all here probably go to our GPs and ask for an antibiotic when we don't need it. We as health professionals here, myself included, probably prescribe it. When I used to do general practice work, you get great pressures from patients, so you prescribe perhaps in your 10-minute consultation you don't need to. Central authorities address the problem are either weak or non-existent. How do you tackle this? It's global. We can do what we like and work fantastically in the UK on it, but what difference is it going to make if drugs are sold over the counter in huge amounts in countries overseas, in India and Thailand, elsewhere, in all kinds of places? The regulatory mechanisms are often less strong. Policy responses discount the future irrationally. And what some of the arguments have been in the policy and ethics literature have said is, with these kind of super wicked problems, and I'll present to you that AMR might be, that's my PhD student's thesis, that AMR is a super wicked problem,